Hi, my name is Becky Sanders. I'm the Program Director for the Upper Midwest Telehealth Resource Center. Thank you for joining us today. What I'd like to start doing today is we've got just 4 short questions in polls. I'm going to go ahead and launch this. And I encourage you to please answer these 4 questions. This will help me learn more about the audience today so that I can tailor my comments to the audience. So question number 1, what state are you from? Question number 2, have you or your organization offered virtual services before? This could be telehealth, telemedicine, remote patient monitoring. What is your organizational role? Are you part of HR administration? Are you part of billing and coding? Are you a provider? Are you a consultant? Do you work for a health department or a government agency? Are you an individual practitioner? Do you work for a health association or other? And then have you participated in UMTRC events before? So I'll give it just a couple more seconds for everyone to fill that out today. All right, the answers seem pretty steady here. I'm going to go ahead and end polling and share these results so that you can see this. So it looks like the majority of our participants today are from Indiana, and we have a good representation of the rest of our region from Illinois, Michigan, and Ohio. So about 1/3 of you have offered virtual services before. We have several consultants. We do have a couple providers, biller and coder, administration, a government person, and other on the list. And looks like 85%, oops, didn't mean to do that. 85% of you have participated in UMTRC events before. So great, thank you for sharing that information with us. I appreciate that. So you'll notice I have marked out the date of March 27th, 2020 and added the date of April 10th, 2020. This was intentional. This is essentially the same webinar we offered 2 weeks ago, but a lot of things have changed as far as regulatory billing, both in CMS and within the states that we cover here in our region. Also, I do want to emphasize that the information that we give is our interpretation, as well as working with the other telehealth resource centers around the country, of the information that we have received from either state governments or state Medicaid programs or the federal government and CMS, and do not guarantee payment. If you need legal advice, I'm not a lawyer, please seek legal advice within your own organization. So we're going to do, already did the introductions. I'm going to talk about the National Consortium of Telehealth Resource Centers, our role as a regional telehealth resource center, and then we're going to get into some technology and telehealth 101, and then we will cover federal and state reimbursement, and then we'll just end with Q&A today. So this map is a map of the National Consortium of Telehealth Resource Centers. The Upper Midwest Telehealth Resource Center operates and covers these 4 states. We're headquartered out of Indiana, but we also cover the states of Illinois, Michigan, and Ohio. So we're one of 12 regional telehealth resource centers and 2 national telehealth resource centers, all funded through HRSA, under HHS and HRSA, and then the Federal Office of Rural Health Policy, and then the Office for Advancement of Telehealth. As a federally funded program, we cannot offer we offer unbiased information. We cannot tell you that you should use a specific vendor. We can give you options and choices so that you can choose the vendor that best fits your needs for what you're doing with your program. The two national resource centers, TTAC is our National Technology Center, and they're headquartered out of Anchorage, Alaska. And our National Policy Center, the Center for Connected Health Policy, is operated out of Sacramento, California. We do have a national website that, as a national consortium, all of the regional and national telehealth resource centers operate together. We have our own brain trust to help answer questions that we might not have come upon before. Our national website, there are national webinars on a monthly basis, and the April webinar is coming up, I think, on the 16th. It's usually the third Wednesday. That's posted on the events on the umtrc.org page as well. My own personal elevator speech, when someone asks me, what do you do for a living? I tell them I'm a virtual librarian. I like this term because so much of what we do is working remotely. The recent stay-at-home orders and shelter-in-place orders didn't change my work life too much, except that we're getting more calls than normal, more emails than normal. I'm used to working remotely, but we do a lot of combing through documents, collating resources, creating new resources when there's gaps, individual consultation to help people figure out how to bill and code correctly for billing of telemedicine. We do a lot of trainings like what we're doing. We've got a lot more trainings on the books for the month of April, and we're actually working on our May schedule right now. So I always encourage folks to sign up for our mailing list so that you get our newsletters. They come out at the beginning of each month, and we'll detail all the events that we've got going on for the month. Screenshots, you can reach us in several ways through our website. We have a email info@umtrc.org, and we'll direct that as needed. We have a social media presence on Facebook and on LinkedIn. All right, I've seen a couple questions. Somebody says that slides are not moving. I am sharing. Huh. Are they still not moving? Okay, so I'm going to try this again. I am going to share my screen instead of that PowerPoint. Let's try this again. I'm going to share screen 2. All right, so now are the slides moving?
Yes, Becky, we're moving now.
Okay, all right. Sorry about that. That was weird. Okay. Technology, gotta love it. All right, virtual librarian. All right, you can connect with us in a variety of different ways. Telehealth versus telemedicine. So I use these terms interchangeably. I'm trying to be more careful as telehealth is becoming more ubiquitous with all of the stay-at-home orders and shelter-in-place orders that are out throughout the United States. When I say telehealth, I mean more the huge general field of technology and healthcare. This could be education, it could be remote patient monitoring, using data from a personal fitness device that your physician is monitoring remotely for chronic conditions, a whole bunch of things. And telemedicine is really that billable clinical service between a provider and a patient who are not in the same location. So there's two types of telemedicine, actually. Asynchronous telemedicine, and this is more for dermatology, sharing data, sharing images. If you had a cut or a rash and you shared that image with your physician, and then they diagnosed that remotely and said, okay, I've called in a script for you for, whatever it is. And then synchronous is live and interactive. So similar to what we're doing today, but if you had permission as an attendee to actually speak and I could see you, that would be a live and interactive connection. Normally, when we're not under a public health emergency, we really focus on HIPAA compliant, secure, real-time audio and video as part of our definition of telemedicine, but we're going to talk about some of the waivers that are going on right now in just a few minutes. So the last thing I want to talk about is that telehealth is not a service in and of itself. You say you want to do telehealth. You don't need, there are certification programs, but there's not another clinical degree to be able to offer telehealth or telemedicine services. You're still offering the same clinical services that you would if your patient was in the same room with you. The only thing that's different is you guys are not in the same room. So we'll talk a little bit about webside manner instead of bedside manner when interacting with your patient. Because of the public health emergency, we have put up a new website, a new page, COVID-19 resources on our website, and they are broken down. There's one for Medicare. There's actually, we've got some new pages with videos. CMS is starting to come out with some videos. We're also starting to see more patient-focused videos. That's one area of telemedicine that has not been explored a lot, is that direct-to-consumer or business-to-consumer information guides and education for patients about how to plan or how to think about what's going to happen in a telemedicine visit. All right, so I told you we're going to talk about relaxation of HIPAA rules. So what has happened is during this public health emergency, CMS and also all the 4 states in the Upper Midwest Telehealth Resource Center region have relaxed their HIPAA rules. What that means is they are not going to cite or assess fines if you're using a non-HIPAA compliant platform. So the language that came out last Tuesday from CMS in their interim final rule is that they wanted you to use a telecommunications system, meaning multimedia communications, including at a minimum audio and video equipment permitting two-way, real-time, interactive communication between the patient and the distant site physician or practitioner. I mentioned the Center for Connected Health Policy before. They have done an awesome job keeping up with the rapid changes that we're seeing in recent weeks. And here's the hyperlink. You'll get the slides. You'll be able to go to that resource that they've put together. And then I mentioned that we have resources on our website as well. In the different states that have issued stay-at-home orders, what they have done as far as relaxing the platform for virtual health, you can see the language here, and they don't all say it in the same words. Each state's a little bit different, but I think this is good guidance here. We see this in Illinois and in Ohio. They don't want you to use public-facing applications like Facebook Live, Twitch, TikTok, or similar, where you're going, you're broadcasting to an unknown audience. There are HIPAA compliant versions of Zoom, of Skype for business, but they're also allowing FaceTime, Facebook Messenger video chat, Google Hangouts, those types of things that are one-on-one conversational audio video applications. You may be in the position where you are starting telehealth for the very first time and you got to get it done right now because of the public health emergency. We're still going to encourage, as a telehealth resource center, that you use a HIPAA compliant platform. Based on all of the folks that we've talked to, both providers and patients, as a provider, you're going to love this. As a patient, you're going to love this, and you're probably not going to want to go backwards. So we're going to recommend that you take a little bit of time and try and put together a HIPAA compliant platform. So how do you find out which platform to choose? This is where the National Technology Center comes into play. And they have a whole health of toolkits. If you click on that first link, there's a clinician's guide to video platforms. Right now, your patients are probably at home, which is different. That was a barrier for both Medicare and Medicaid until very recently. So you're probably not going to worry too much about patient vitals and otoscopes and blood pressure cuffs and stethoscopes. You may want to be assessing that information. And we'll talk more about this, but if right now your patient's at home and the best you can do is, hey patient, grab your thermometer, take your temperature and tell me what it is, then that's what you do. You've got to be creative in these unprecedented times. All right, so if you're a larger organization, you might be using an electronic health record platforms such as Epic or Cerner or Meditech, or you might be a Cisco shop or a Microsoft shop. Check with your internal IT infrastructure and see if you have the ability to use existing equipment, existing platforms that have video conferencing components to them. I know for sure that Epic does have a video module built into its system. I know that folks that use Epic often use MyChart for their patient-facing portals, the provider portals. Those can be used for telemedicine. So there's a lot of options out there. So actually, let's go back. I'm going to look and see. Okay, it looks like we're good. All right. I saw some questions going on here. I wanted to check. Doesn't look like there's anything I need to pay attention to right now. All right. So developing a telemedicine program. Normally this is something that we talk about and you within your organization would want to take 6 months to plan. Right now, if you've never done this before and this is your best option to take care of your patients, you don't have 6 months. So I'm going to talk you through this pretty quickly and give you some additional guidance, point you to some information on our website. There's basically 3 steps here. We're going to assess and define, develop and plan, and implement and monitor. So it's, if you've heard of the Plan, Do, Check, Act, it's very much like that particular tool. And when I talk about developing a telemedicine program, it's a different culture. So I love this book that I read back in the mid-90s called Who Moved My Cheese? And if you haven't read it before, I strongly recommend it. It's a really quick read. But in this book, there are 4 characters: him, haw, sniff, and scurry. And so you can see them in their quadrants. Him is our stabilizer, sniff is our innovator, scurry is our producer, and haw is our unifier. So if you think in your organizations, you probably have people that have these different personalities in your organization already. And when you work as a team, because providing telemedicine is a team effort, you need nurses, you need doctors, you need IT, you need billing and coding, you need administration to have the buy-in, you might need finance to purchase equipment. You got to work together as a team within your organization. So along comes COVID-19. We have a lot of resources existing on our website, getting started guides. We've added some additional information to that, and then there's a ton of information in our new page, our new COVID-19 resources on our website. And if you email us, you can we can help point you to the best resources to help you for where you are at the time. So when we talk about telemedicine room design, and this is the kind of pre-COVID era type of stuff, we talk about the location of the telemedicine room, equipment, furniture, lighting, all of these kinds of things. Pre-COVID, the patient would be sometimes usually in a rural facility, could be an urban facility, but they're in a patient room, just a basic primary care clinical patient room. And the amount of room needed for the patient is going to depend on what's going on, why they're being seen via telemedicine. Because the patient could be in a primary care office and receiving psychology services, behavioral health services from a provider that is at a remote location. It could be a follow-up on an ortho visit, or all kinds of things. So now when we're talking about seeing patients at home, there are some additional things that we need to think about. Privacy is a big one. If they're in a clinical setting, you can control that. If the patient is not in a clinical setting, you can't really control what's going on around them. You might start off asking questions. Are you alone in the room? Where are you located? Are you at home? Are you, those types of questions to determine where the patient's at and make sure that they're safe. As far as website manner, if I was the provider, I don't know. I see what I can see from my webcam view. I don't know what else is going on in that patient's space, and the patient doesn't know what's going on in my space. I could have, I have a physical banner behind me to make my area look more professional, but there could be all kinds of stuff. If I've got someone with me as the provider, I'm going to say, hey, I've got someone else in the room with me observing, or whatever, and try and include them in the video that is being broadcast. We did some presentations this last week for diabetes educators. Normally, diabetes educators, they sit down in the same room with their patient, and they have plates that talk about the different kinds of portions of carbs versus green leafy vegetables versus protein that should be on a plate, or sample sizes to show portion sizes. Well, when the patient's at home, and the provider might be at home, they might not even be able to get back into the office right now to grab the stuff that they normally use as their aids. So you might have, a deck of cards, or a cell phone, or something else that you pick up and say, okay, now this is the portion size. It's the size of your fist or the size of your thumb. You're going to have to be creative in how you try to educate the patient during the visit. Video etiquette, I'll show you some things not to do here in a minute, but I have crafted the space around me. I've got my room, my door closed, and it's locked, and everybody else in the house knows not to bother me right now. I have a special daylight light that helps shine daylight. I've tried to close off my window. It's kind of morning, so I'm getting a lot of sun in, so it's a little bit lighter over here than over here. But I've done what I can to minimize that. Patient consent. We're getting a lot of questions on patient consent. We do have sample consent forms on our website and our resources. We're also going to do a virtual office hours next Tuesday, specifically about consent and documentation. So I'm not going to spend too much time on it today. Vital signs. If your patient is not in a clinical setting, then there's not a med assistant or another clinical person to take those vitals from the patient. You're going to have to rely on the patient. If they probably have a thermometer. They might have a blood pressure cuff, and they might have other items. There are so many things, so many technology, so much technology available, even from Best Buy or from Amazon, that patients can use with their cell phones, with their smartphones, to take all kinds of vital information. And right now I would document it that it came from a patient or consumer device, and that the vitals were not taken by a clinical professional. Any questions on that? All right. Again, pre-COVID, I would spend a lot of time talking about a work plan. You still need to have a work plan, even if it's only going to last 1 week. You still need to think this out, plan this out just a little bit. You might start with patients that are technology friendly, or you start small, let the word of mouth dictate how fast you move forward, depending on type of services that you provide and whether or not they lend themselves to telemedicine. Regardless, you want to make sure that you have goals and objectives that are SMART. So specific, measurable, achievable, relevant, and timely. If you have a strong basis and you know where you're starting, then 6 months from now, you can go back and look and say, hey, I have accomplished these things. And if you start tracking data for outcomes at the beginning of the program, then you can very easily go back and see where you are in a month, in 6 months, in a year, and tweak the program as needed. Because the best way you're going to learn how to do this is by doing it. All right, so here's some things not to do. I've set up my pretty background so you can't see all of my clutter in the back. I've been trying really hard to focus on the webcam up here and not looking down. If I needed to look down to take notes, what I would be nice to do to tell the patient is, okay, hang on a second, I'm going to make some notes and I'm going to go down here and take some notes. But I do have a separate screen over here. So I might say, okay, hang on a second, let me document this. And I go over here on this screen and I'm documenting. So clean and uncluttered. I've been talking about this all along. You want a clean and uncluttered view between your face and the webcam that you're using. I've already talked about trying to eliminate shadows, putting a light in front of me, and avoiding backlight. I do not have my overhead light turned on. And these are things that you can talk with your patients. You can create patient resources to help them to have an optimal telemedicine visit. Acoustics, you don't normally have to worry about this too much when the patient's at home because they probably do have carpeting or some type of area rugs. Hopefully they don't have noisy HVAC. There's probably not a lot of traffic going by outside. But you can, if in a clinical setting, you can do a lot of things with sound dampening tiles in the ceiling. So there's actually sound dampening paint out there. So if you were talking about a clinical setting, you might think about painting the walls in like a light gray or a light blue. Those are shown to be ideal wall colors for telemedicine, and they work well with all skin tones. All right, so now we're going to jump into telemedicine law and policy. I do see a question about our FQHCs and RHCs. We haven't set up a specific section or a specific webinar or virtual office hours on that. I would have you contact us, and my email will be at the end, or you can use info@umtrc.org. We are starting to get a lot more questions from FQHCs and RHCs, and we can certainly speak to that. So Medicare pays based on conditions of payment. A lot of these have been waived during the COVID-19 pandemic. So we'll talk about those. Normally Medicare only pays if patients are in specific eligible originating sites in rural areas. Medicaid, none of the 4 states in our region, Illinois, Indiana, Michigan, Ohio, have a distance limitation on the patient distance to the provider, nor do they have anything that says the patient must be in a rural area. As of the spring of last year, all 50 states and Washington, D.C. do cover live and interactive telemedicine. So these are the 4 conditions that we normally talk about with Medicare. Since the beginning of March or mid-March, the rural location outside of a metropolitan statistical area and patient in the designated originating site have been waived by Medicare. So the patient can be seen at home. At the end of March, they added 80 new CPT codes. So they expanded the list of CPT codes. By expanding the CPT codes, they sort of expanded the list of eligible providers, but not really. Biggest area where we're seeing issues with this is physical therapy, occupational therapy, and speech therapy. There's still a little bit of clarification that needs to be made there. Normally, when we talk about Medicare reimbursement, we're talking about the HPSA rule eligibility lookup tool. Again, this doesn't matter right now. This is waived during this public health emergency. Every year, Medicare does come out with their annual Medicare Learning Network Telehealth Fact Sheet. And that has been updated for 2020. This is what it looks like. It just lists the codes that are eligible for telehealth or telemedicine. And they did put in a new this is one part of my slides I forgot to update. I apologize. We'll get it updated before we post it. But they did put in a new page in their learning resource that is specific to COVID and has a couple of extra links in it too for COVID resources. So we'll get that updated. Let me make a note on that so I don't forget. What they also have done by eliminating the need for the patient to be at an eligible originating site is this Part B facility fee is not going to be billed. If the patient's at home, they're not at an eligible facility, so we're not going to bill that Q301 form. What that is designed to do is to recover lights and rent for the physical space where the patient is being housed or being roomed during the telemedicine event. What is going to happen is you're going to bill the normal CPT code that you would bill if the patient is in the office. You're going to bill that with modifiers, and we'll talk about those modifiers. It's going to be different if you're billing state Medicaid versus Medicare. They're going to be a little bit different. Ah, here it is. This is the sheet that I was thinking of. So this has got all of the COVID information on it, links to the different fact sheets and frequently asked questions that CMS has put out. All right, and then so we thought we had our minds wrapped around everything when we did our webinar, just like this one 2 weeks ago. But then on March 30th, CMS introduced 80 new codes that were available for reimbursement via telemedicine. I'm not going to read through all of these things. You'll get the slides. I'm just going to kind of gloss over. So we've got nursing facility visits, initial hospital care and discharge planning and management, critical care, rest home, home visits for new and established patients, neonatal pediatric care, care planning, neurological testing. And see, here's the thing with the therapy services. So they added these codes for therapy services, and they say licensed clinical social workers can be paid for as Medicare telehealth services. But they didn't specifically say, they're talking about the services, not the actual provider. Got a couple questions here. Currently, pharmacists who can deliver diabetes self-management education services in person are not an approved provider of DSMT services via telehealth. And let me pull up I think you're right. That's something I hadn't thought about. So the list of distant site practitioners for Medicare does not include pharmacists. Yes, that is true. I hadn't thought about that. Because in person, a pharmacist could deliver those services, but they're not on the telehealth list. Let me make a note on that. So I answered that. Can the physician provide E&M services via telehealth from his home? Yes. That is part of the waivers that have happened, is the physician can be located anywhere. Your list of CPT codes, something about pharmacy services. Let me go back. Home patient. I will check on that and get back with you, Brenda, on that. Yes, so if a So if a pharmacist is teaching about insulin, they could not get reimbursed for Medicare. And I will have to dig into the specific state Medicaid, because that's not something I was looking for initially. Nurses for DSME, yes. So the list, again, I don't have it captured in a slide, for Medicare distance site practitioners includes physicians, physicians, nurse practitioners, physician assistants, nurse midwives, clinical nurse specialists, certified registered nurse anesthetists, clinical psychologists, and clinical social workers. Registered dietitians or nutrition professionals. So depending on what type of a nurse, maybe the answer is yes, and maybe the answer is no. Do providers need to reapply as working from home? No, they don't. There is a specific waiver out about that, and if you want to email me, my email will be at the end of the slide deck, and I can find that waiver for you. But no, they do not need to. There was some questions about that early on. That's a great question. At first, we thought that providers that were now providing services from home would have to update their information with Medicare about their provider location and put their home address, but they have waived that. All right, I saw a new CMS today, or maybe late yesterday, came out with a new video that specifically talked about virtual visits and e-visits, because that's been a very common question, especially dealing with Medicare patients that may not be very technology friendly, may not have a smartphone or a tablet or a computer, and all they use is the telephone, about telephonic visits. So we will be posting today, and also Autumn, that video I sent you this morning to post under the COVID provider resources, can you include that YouTube link when we send out the slides and the recording for today?
Yes.
Thank you. And that'll help answer a lot of the virtual check-in and e-visit questions. It is 15 minutes long, but it's really worth it to get through it, because it really highlights different, and they're not paid as normal visits. That's one thing that Medicare has not done. If you're going to use telephonic, then it's not going to be paid like a normal office visit. The rate is a lot lower. These virtual check-in codes here, the G2010 and G2012, they're only about $15. They're not a lot, but they were designed as quick check-ins, between a patient and provider. They weren't designed to be a normal E&M visit, a normal physician provider or normal physician patient visit. So these codes here, I have not looked up. I'll put that on my list of things to do. I have not looked up these codes here for the telephone services, but I imagine that they're lower than the normal office rate. Remote patient monitoring. So here's a whole bunch of codes for remote patient monitoring. And then some really good things came in at the end of March regarding subsequent nursing facility visits. It used to be that they could only be seen via telehealth once every 30 days, and an inpatient in a hospital could only have a telehealth visit once every 3 days. So these regulatory limitations have been removed. Some other really, really good things about physician visits: just waiving of requirements, waiving of supervision. This is good for physician assistants. So all kinds of things. And there was I saw another bulletin come out today. We'll put it in our list of resources on our website. And it was some more waivers. So we're trying to update everything as quickly as we can. Here's the thing about, we were talking about practitioner locations. So here's that. They still have to be enrolled in a program and have a valid license. All of these things, they have to basically be in good standing. So there's some new hotlines set up for provider enrollment. You know, specific to the state of Indiana, a couple of weeks ago, our governor talked about, they had put out a call for retired practitioners or practitioners that really weren't serving in their clinical capacity. And they had 5,300 people just in the state of Indiana say, yes, I will step up and I will come back and I will serve during this crisis. So those are great stories. These waivers that came out on March 30th also include Stark Law waivers, so EMTALA waivers. There are some changes to MIPS and there's accelerated payments or advanced payments that you can apply for. Basically, it gives you additional funding right now because you're not seeing your normal patients, you're only seeing critical patients. And then there's different guidelines about how long you have to pay those back. I don't remember them off the top of my head, but it's in the interim final rule and the guidelines here. So if you follow these links. All right. If we have anyone on here that deals with medication assisted treatment for SUDs or OUDs, this is important information from the DEA. There's the link to their site. They have some links to different policy and guidance about prescribing of controlled substances via telemedicine, and a whole section on telemedicine. So basically right now they have waived the initial face-to-face. So because of the public health emergency, telemedicine is allowed under this section of law. It applies to all Schedule 2 through 5 controlled substances. You still have to be a DEA approved provider or facility to do that. And they still want you to have an audio-visual, real-time, two-way interactive communication system and applying to any state or law. So basically you have to be in good standing. So that's great to hear. There was a question earlier about FQHCs and RHCs. I'm going to address it just a little bit today. I'm not going to do a deep dive. Please contact me and we can talk offline more about that. The biggest thing to know about FQHCs and RHCs, in our 4 states, Illinois, Indiana, Michigan, and Ohio, FQHCs and RHCs could already be either the distant site or the originating site. So they could be either the provider site or the patient site. Medicare did waive this with the CARES bill that passed on March 27th, because for Medicare, FQHCs and RHCs, and this includes lookalikes, could only be the originating site, could only be the patient location. So now they can be either. So there are some really good state Medicaid guidance on this, and I've been digging into the Medicare guidance on this. It's a lot to go through and to understand, but certainly follow up individually if you have additional questions on FQHCs or RHC billing for telemedicine. All right, I'm going to spend just a little bit of time talking about the individual state Medicaid programs, and this is all pre-COVID, knowing that all 4 states have shelter-in-place orders. Patient and provider can now be at home, and we talked about the HIPAA compliant waivers. So basically, use your best judgment, use your best creative ability to get those consent forms to document the visit, and to use HIPAA compliant technology whenever possible. And I don't remember off the top of my head about states Medicaid waivers and telephone, but I think if that's the best thing you can do, I think you're okay using telephone. All right, so Illinois Medicaid already reimbursed for physician assistants, podiatrists, and advanced practice nurses. They have opened that up. They have allowed basically any type of clinical provider to be able to provide telemedicine during this pandemic. They want you to bill with the appropriate CPT code with the GT modifier. Illinois Medicaid does not reimburse for store and forward. They do cover home uterine, and they do have a partial parity rule. And right now, during the public health emergency, Illinois and Ohio, when we get to Ohio, didn't have full parity laws, and the parity is where a commercial insurance provider like Anthem or Blue Cross, United, Aetna, didn't have to cover telemedicine services. But right now, they've all come out with guidance on that. There is an AHIP, American Health Insurance Providers fact sheet that I just found yesterday. It's not included in these slides that we can also send out, that said by individual insurance company what they're doing. So they all should be paying for telemedicine at this point during this public health emergency. And there are hyperlinks at the bottom of each of these pages for the states. They have not been updated for COVID, but we will work on that as our call volume is starting to drop off. We'll have more time to get those updated, include those COVID resources directly in the guidance for each state. Right now, go to your COVID, to the umtrc.org COVID resources page, find your individual state there. Indiana Medicaid reimburses for live and interactive, but not store and forward. Here we again talk about patient consent. I mentioned we have consent forms on our website. If the best that you can do is a verbal consent, then get the verbal consent and document it. Already back in 2017, Indiana passed a law that said provider and patient relationship can be created during the first telemedicine visit. So even if you haven't met with that patient in person, in an in-person visit, you can still do that. There are certain clinical standards. The link below to our reimbursement stuff gets in links to the Medicaid standards guidelines, so you can see those clinical standards. The biggest thing about this was it allowed prescribing via telemedicine. They're basically talking about antibiotics there, and then there's specific rules that were enforced back in 2017 about issuing patients controlled substances prescriptions via telemedicine. And then right now the DEA has come out with new guidelines that trump those particular rules. Indiana does have a commercial parity rule in place. At the beginning of 2020, Indiana also added additional codes for speech, language, and voice communication. So those are now in effect as well. Michigan already reimbursed for a wide variety of healthcare professionals. They don't do store and forward. They do have language about consent. And they do have language about prescribing of controlled substances, and they already had a parity rule in place. Now, just prior to the pandemic conditions and the public health emergencies, and when the Michigan governor came out with those, Michigan Medicaid had already planned to open things up to allow patients to be seen from home. So they've got some really detailed information. If you click through and look at the Michigan Medicaid public health bulletins, they have listed all of their codes, and these are what they look like. But they've detailed all of the different codes that they're paying for now via telemedicine, and some are temporary during the public health emergency, and some are permanent. Ohio made a lot of huge sweeping changes in the middle of 2019, effective 7/4 of 2019, where they already were allowing the patient to be at home for a telemedicine visit. Their parity law was approved last July, but it wasn't supposed to take effect until January 1st of 2021, based on their budget years. But now, during the public health emergency, all commercial providers are paying for telemedicine. All right, we're almost at the end of our time. Looks like we've kept up well with the questions. Let's see. Patient remote provider. Excuse me. This says remote patient monitoring providers can review a patient with diabetes download from their continuous glucose monitor, CGM, and can collaborate with their patient around high or low blood glucose and identify ways to get their blood glucose closer to the normal range. I think that's a statement, and I think that's correct with remote patient monitoring. For an E&M code via telehealth, audio-visual. Oh, have they waived the this is a good question, and no, I haven't addressed it. Medicare and Medicaid have not, especially Medicare. I believe there are telephonic allowances in state Medicaid policies for the 4 states that we cover. But there's only those specific phone codes in the list of the 80 new codes under the virtual care check-in section. Let me go back to that. So Medicare has not, for normal E&M codes, they are not allowing telephonic due to unstable broadband or patients that don't have internet access. So the codes here, 98966 through 98968 and 99441 and 99443 can be provided via telephone, but they're not going to be the same reimbursement as a normal E&M code. So there still is that. Now something that, let me find, and I will put this in the chat. Or actually, you know what? I'll send it to Autumn to put out when we put out the slides, is the Lifeline program. We were talking about this yesterday with the diabetes education that we were doing. So if your patient basically is on any type of social assistance, if they get Social Security, if they are on WIC, if they have SNAP, those types of things, then they have a certain percentage below poverty level, or whatever that happens to be. There is a federal communications program called the Lifeline program. It is administered by the Universal Service Administrative Company, and I'm going to write myself a note to send a video, CMS virtual, and also link to Lifeline. So what this Lifeline program does is it allows for subsidies for the patient to be able to have either subsidy on their landline or cell phone bill or a subsidy on their internet access to make it more affordable for them. So that may be an opportunity for a patient to get better internet access. There are also two programs, one just the press release came out, but not the order. So the first is the Connected, I think it's the Connected Care Act. That has been put out by the FCC, and that's additional funding for telecommunications providers to build out fiber and better lines to make internet access more available to residential areas. Previously, the rural healthcare program within the Federal Communications Commission was really targeted more at businesses and healthcare organizations. So this additional funding is now available. I think it starts May 1st to apply for it. But to really, truly to that last mile building out of telecommunications infrastructure to residential homes. Then the second one, and I'm not gonna remember the name of it correctly, is really for covering remote patient monitoring devices for patients to have devices in their home to enable them to communicate better with their providers. So if there's interest, I can send links to both of those as well. Patient. All right. So just some basic questions that I've tried to cover as we've gone through today. So I'll cover these really quickly, and then if there's additional questions, go ahead. Now's the appropriate time to go ahead and put them into the Q&A. So do you need any special credentials to provide telemedicine? No, you do not. As a clinical provider, you have the licensing that you need. You just need to develop the skill set to be a little bit more website manner friendly. What equipment do you need? Must you use video? Do you need a headset? Really, it depends on the platform that you're using. If you've got a good microphone and a good speakers, you probably don't need a headset. But if you're in a noisy environment, you might want some noise canceling headsets. Again, these are available Amazon, Best Buy, any technology store. Really what you're going to want to do is invest in, and you can with a smartphone if you've got good internet access, or a tablet. Most of any laptop that you buy today is going to have a built-in webcam. That's just where technology is at, and that's really all that you need to have a voice conversation with a patient. Is telemedicine appropriate for all ages and or all specialties? Use your best judgment. Kids usually love it because they've used FaceTime or Skype or whatever, some type of video chat with their friends or their relatives. And surprisingly, a lot of older patients like it too. One thing that's really interesting is in the behavioral health world, patients seem to find telemedicine, they seem to share more via telemedicine because they feel more secure. They're not in a strange location. They're able to stay in their home, especially now they're able to stay in their home in a familiar location and they feel safer. Can telemedicine be used for new patients or only established patients? The waivers there's a multitude of waivers out there allowing for new patients to be seen via telemedicine. It remains to be seen what will happen once the pandemic has passed. Restrictions around prescriptions for controlled substance, we've talked about those. There's the DEA waiver and guidance from the DEA included in this packet of slides. Can you order outpatient tests or labs for a patient during telemedicine? Yes. Can meds be prescribed? Yes. Controlled substances, we've talked about that. We've talked about performing a physical exam and how you get vitals when the patient's at home. Just use your best judgment, document. What if patients need to be seen in person? Follow your organization's emergency preparedness clinical protocols. If an in-person visit is determined necessary, can I still bill for the telemedicine visit? Yes. What is the reimbursement? The reimbursement for telemedicine should be the same as the in-person visit, and it's going to depend on who you're billing, if you're billing Medicare, Medicaid, or private insurance. How long should you schedule the visit? Schedule it the same amount as your normal visits, and then you can adjust as necessary. What about collaboration rules? We saw the waivers that came out at the end of March for physician supervision. Collaboration rules as well follow under that. And once the pandemic is over, do I lose my ability to provide telemedicine services? No, most of you are probably already were able to do telemedicine. You just hadn't taken the step forward to do that. And take baby steps. The best way you're going to learn is by doing. And just again, the links to the Center for Connected Health Policy site. If you go on their site, you go under Telehealth Policy and Resources, you can see the current state guidelines for your state. Again, we have our resources on our website for the COVID-19 pandemic. And again, you can reach out to us on our website through LinkedIn or through Facebook. And there is my contact information if you need to get a hold of me directly. Advise on examination for telehealth. I've talked about vitals and video etiquette. I'm not sure what you're asking. Can you be more clear? All right. Thank you for attending today's session. I hope it was useful. Please follow up with us if you have any additional questions. On the physical exam for the patient, you're going to have to, you obviously can't touch them through a webcam. So if you need to do palpitations, you're not going to be able to. You're going to have to trust the patient to do it themselves or have a family member do it for you, for them. These are unprecedented times and you just got to do your best. Or you may decide that telemedicine is just not, if they think they've got a broken bone, then don't see them via telemedicine. Tell them to go to the nearest emergency department or urgent care clinic. So thank you. And I think that I hope this was helpful today, and hope you guys all have a great weekend. Happy Passover, happy Easter. Stay safe.